All right, we're going to do upper GI, and then I'll probably have to do a separate small bowel follow through. So, know your stomach anatomy, know your intestinal anatomy for me, okay? 4 main parts: the cardia, fundus, body, and pyloric portion. Obviously, 2 curvatures and your sphincters, okay? Make sure you review those. Cardiac orifice, opening between the esophagus and the stomach, controlled by the cardiac sphincter. Pyloric orifice, opening between the stomach and the small intestine, controlled by the pyloric sphincter. How to remember that? C becomes before P. So I remember the cardiac is up at the top here. The letter C, go by the alphabet, down to letter P. All right, just a quick. The rugae are your folds, your stomach folds. Okay. Something important I want you to remember is that the fundus, this top part of the stomach, sits posteriorly to the body, which is anterior, and the pylorus is actually a little bit posterior too. So that'll come into play in a few minutes here when we talk about where the contrast moves per patient position. The upper GI, we're looking at esophagus, stomach, and the first part of the small intestine, which is the duodenum. Most often we're using barium or a water-soluble contrast if there's any question of perforation. We don't often use the thick barium in the physies anymore, depending on your radiologist, but you're also going to want to have a cup of water and a straw out on your counter as well. When we start with the fluoro, the patient will be positioned upright, then supine, prone, RAO in a drinking position, and then left and right laterals. We're going to move the patient into different positions to allow the barium and air to move into the anatomy that's being imaged. If they can't stand, if they're a house patient, they come down on a stretcher, we're going to slide them over to the table supine, roll them into lateral position, and if they need to be at a certain angle, we have some sponges that we'll use to prop them up. If they have a feeding tube, we may inject through the feeding tube instead of having them drink. You're going to ask your patient their history, but before you do that, I want you to really look at your requisition and read the reason. What is the reason that this patient is coming in for? Ask your patient, have you had anything to eat since midnight? Remember that NPO term, nothing by mouth, right? Is there any chance you might be pregnant? Have you had any surgeries to chest and abdomen areas? I specify the areas. If you just ask a general, have you had any surgeries? You're going to be there all day because your patient's had 20 surgeries and they want to tell you about all of them. What brings you in? What symptoms are you having? How long have you been having them? Does anything make it worse? Make it better? Have you had this done before? They're going to explain this procedure in terminology that they can understand. So don't tell them don't use specific terms. We're going to give you some contrast to drink. We're going to stand you in these positions. We're going to take our images. It's a white contrast, but when it's hit with x-ray, it shows up black so we can see your anatomy, something like that. Have your patient changed completely waist up, including earrings, necklaces. The gown is going to be on opening in the back. If they have pants that are kind of high up in the waist, or if they have a small bowel follow through in conjunction, they're going to change it to hospital pants as well. I have a pet peeve about patients having their gown open in the back, so sometimes I give them a second gown just to make them more comfortable. These are just some reasons a physician may order an upper GI. Your patient could have difficulty swallowing, chest and abdominal pain, possibly reflux, unexplained vomiting, indigestion. Blood and stool is an indication of GI bleed. So those will be reasons that your physician has put in. And then these are a list of possible clinical questions that they're asking the radiologist to prove. And I'm going to go through some of these. A peptic ulcer is right here, okay? Hiatal hernia, and the hiatal hernia is when the upper part of your stomach bulges through the large muscle that's separating your abdomen and chest. That's called your diaphragm, right? And it's usually because that muscle is a little bit weakened. And you can visualize a hiatal hernia here where these 2 arrows are and this line is here. Because the diaphragm is actually still kind of pinching in, but it's being pushed up through. So like this image here, you have this little bulge here, okay? This is a huge hiatal hernia that's pushing into the patient's chest. And this patient is clearly upright in this image because, remember, air rises, fluid drops. We have a line going across the image here. Okay. A bezoar, it's a mass that's found in the GI systems that's formed from the ingestion of hair and sometimes fingernails. Gastritis, inflammation of the lining of the stomach. So normally this is a thickening of rugal folds. And then this is an absence of rugal folds due to some inflammation. This picture is just for anatomy purposes. Pediatrics, upper GI. Most of the time we are looking for something called malrotation. Usually these kids are vomiting excessively. Everything they eat they're vomiting, or they're just really miserable and they're not gaining any weight. So a lot of the times physicians will question if they have malrotation. That means their intestines are essentially rotating in the incorrect direction. All pediatrics at our facility are done recumbent. Even if they're 18 years old, most of the time they'll be done recumbent. NPO for infants is only 2-3 hours, so it doesn't have to be the NPO from midnight like adults do. Our radiologists usually start with a scout of the abdomen with the fluoro machine, and then we put them into different positions and have them either drink through a bottle, drink through a sippy cup, drink through a cup with a straw. If they're 6 months or under, you're going to mix that barium with sterile water because we don't want to use the water out of the sink for a child who hasn't had any exposure to any of that type of water, okay? And then you're going to have the parents assist the whole time with lead on, have them talk to the child, calm the child down. The only overhead that we do routinely for upper GI at clinical is the AP stomach. So you're going to do 14-17, center to L1, which is usually around the lower costal margin. And a little trick I have is right by the patient's elbow. So if you extend their arms kind of flat down, around their elbow is where their top of their stomach usually is. I do lengthwise for slender patients, crosswise for larger patients. Technique, you need to increase your technique to 110 kVp for barium work. Some rooms use 109, but don't be sort of taken aback by that. It's really similar. I always look at my patient first and say, what would I use on their KUB? You guys know KUB technique at this point. So, you know, are they a 20 at 80? Are they a 25 at 80? Are they a 40 at 80? Whatever you think you'd use for your KUB, you take that KVP and you increase to 110. But remember, anytime you increase your KVP by 15%, that is going to double the exposure to your patient. So what do we have to do to our mass? You want to half your mass to compensate for that increase in KVP, right? So keep that in mind. The AP GI, the barium is going to be in the fundus. For a sthenic patient, you're going to center right to L1. Hypersthenic, that sort of, you know, shorter, wider, stockier patient, 2 inches above. Asthenic is that thin, tall, longer torso, 2 inches below because they have that long J stomach. All right, and for any of your upper GI overheads, these are the same. Sthenic L1, hyper 2 inches above, asthenic 2 inches below. AP supine, you are going to have a fundus filled with barium. And I like this little sentence. It is fun to lie on your back looking at the clouds because I feel like this looks like a little bit of a cloud. So if you imagine you're supine on your back, you're looking up at the clouds, you're supine, it's fun. Your fundus is filled with barium, and you guys are going to think I'm silly. PA, same central rays as the AP, all right? Except you're going a little to the left of the vertebral column because when you're prone, you're compressing everything. On the PA, the body and pylorus are barium filled. There's going to be air in the fundus. Why? When you are prone, remember that fundus that we talked about earlier is posterior. So it's up. So air is going to rise. The body and the pylorus are going to be closer to your image receptor. They're kind of down closer, so the fluid's going to drop. All right? So prone, air in the fundus. This was just a little kind of air barium picture, but don't get confused. In this picture, the black is air, white is barium. This picture here on the left is a supine because there's barium in the fundus. This image is an RAO position, so the patient is prone, but in an oblique, there is air in the fundus. Quick quiz yourself. Which one is prone? Which one is supine? Yep, you guessed it. A is prone, B is supine. Textbook overheads that you're never going to see at our clinical site. There's an RAO of stomach. These are going to use 10 by 12 cassette. It's a 40 to 70 degree oblique. And we're still going for L1. The degree of obliquity gets steeper the larger body habitus. So your hypersthenic, your kind of big patient here, they're at the 70 degree end. Your asthenic is at the 40 degree. And your sthenic, they're sort of in the middle. The RAO, how do I know this patient is an RAO when this image pops up on my screen? Personally, I look first, where is the barium? Is it in the fundus or in the body? Automatically, I know this patient is in a prone position because there's air in the fundus. Then I look to my spine. Do I see spinous processes coming down the middle? Nope. I see Scotty dogs, right? Here's the pedicle of the Scotty dog coming through here. So ding, 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 that means my patient is in an oblique, right? So which way is my Scotty dog facing? This patient is in an RAO. Right lateral, still 10 by 12, going L1, but you're a little anterior to mid-coronal plane, right? Because your stomach is a little bit anterior to your vertebrae. What am I looking for on the lateral stomach image? Ideally, I'm looking for this retrogastric space, which is behind the stomach. How do I know this is a lateral? I look to my spine. Is my spine in true lateral position? Yes. And why right side? We use gravity, right? You turn your patient on the right side, the stomach is going to be up in there. It's going to pull that contrast out of the stomach. So if you ever eat too much, go lay on your right side. You'll feel better. LPO is used if the patient can't do an RAO. The degree of obliquity is 30 to 60 degree oblique. You can use a 10 by 12 cassette. Right. We're still near L1 here. And again, the larger body habitus, you're going to be at the steeper end of your oblique. So asthenic is your tall and thin, 30, hyper 60, and then your sthenic, they're in the middle again. They're kind of your mid-range. LPO is where I want to see my duodenal bulb. And you guys that have been in fluoro, I'm sure you've seen your radiologist have the patient on their left side. They take the patient by their hip and they sort of rock them back and forth into a steeper or shallower LPO to find that duodenal bulb shot. Just an image here of anatomy. Body habitus. I need you guys to know this information. So know the names, hypersthenic, hypo, asthenic, these terms and percentages. I also want you guys to focus mainly on stomach and duodenal bulb location. We'll get to large intestine later on in our semester 3 when we do BE work. All right, this is just another image of where anatomy will sit per body habitus. And notice they combine this hyposthenic and asthenic as far as body habitus goes. These 3 images here will be on your test. So hyposthenic, where is the duodenal bulb in each? So make sure you memorize those 3. Okay, I'm going to stop here and I'll move on to small intestine by itself.